Welcome to the Acute Medical Teaching Series. We are your hosts,
Shifona
and Harrison, both senior house officers from Salisbury District Hospital.
This is a 12-part teaching series running over 3 months. You can find links to the other sessions on our YouTube channel or via Blackboard for the local Southampton students. Don't forget to complete our feedback form attached below.
This is our 6th session, and we will be looking at Community Acquired Pneumonia today.
So what is Community Acquired Pneumonia? It is a pneumonia which develops outside of the healthcare setting, so not a hospital or nursing home. In cases of hospital-acquired pneumonia, there are different microbiological causes, which means different antibiotics are often required.
It is typically characterised by evidence of consolidation on a chest X-ray with clinical evidence of infection, for example raised inflammatory markers, a productive cough, shortness of breath, or fever. Here we can see an example of a chest X-ray of consolidation. On the left lung you can see nice clear pleural spaces with a normal heart border and a normal costophrenic angle. On the right lung you can see consolidation in the right upper zone.
We know this consolidation occurs due to the production of intra-alveolar exudate due to invasion of pathogenic organisms in the lung tissue. Note, however, there are other non-infective causes of consolidation, such as lung cancer and pulmonary edema, which you should keep in the back of your mind.
There are multiple causes of community-acquired pneumonia, but the main causes consist of Streptococcus pneumoniae, which accounts for about 80% of cases. And it has a very textbook presentation, which will be a sudden onset febrile illness with pleuritic chest pain. There are also viral causes such as influenza, RSV and COVID, and there are other bacterial causes such as Haemophilus influenza and Staphylococcus aureus. Of note, Staphylococcus aureus is normally most common post a recent influenza infection. There are also atypical causes of community-acquired pneumonia such as Mycoplasma, Legionella and Chlamydia. These organisms are atypical as they cannot be gram-stained due to a lack of a peptidoglycan layer within their cell wall or a very small layer. As beta-lactams such as penicillin target this cell wall structure, we know therefore that penicillins are not effective in this group and we need to consider alternative antibiotics such as tetracyclines, for example doxycycline, or macrolides, for example cliframycin.
Typical clinical features of community-acquired pneumonia include a productive cough, shortness of breath, pleuritic chest pain, rigors, fevers, confusion, and coarse crackles on auscultation.
Next we will move on to investigations. We've mentioned a chest X-ray earlier, and we know this will show evidence of consolidation. However, if the chest X-ray does not show any evidence of consolidation but there are clinical features of a respiratory infection, this is then defined as a lower respiratory tract infection. As you can see on the screen, there are multiple examples of consolidation seen on these chest X-rays. You may also see associated infected pleural effusions as seen on the right, where you can see a loss of the costophrenic angle and an associated fluid level. Additional investigations include routine bloods such as a CRP, FBC, Usinase and LFTs. It also includes measuring their oxygen saturations so we can provide additional oxygen therapy to these patients. We also often take sputum cultures and blood cultures in an attempt to identify the underlying organism, and we can also perform urinary antigen tests, namely checking for Legionella and pneumococcal urinary antigens, as this can also help us identify the underlying cause. We can also perform an enhanced respiratory viral screen, and in Salisbury this is known as a biofire panel, where there are multiple PCRs done for different organisms, and we can therefore also identify the causative organism from this.
So how do we go about grading the severity of a community-acquired pneumonia in hospital? We use a scoring system known as the Curb 65, as you can see on the screen.
As seen below, confusion will get you a point, a high urea will get you a point, a raised respirate will get you a point, a systolic blood pressure below 90 or a diastolic below 60 will get you a point, and an age greater than 65 will get you a point, and then this gives you your total score out of 5. We can then use the Curb 65 score to give us advice on how to manage the pneumonia. A score of 0 or 1 suggests that we should consider outpatient treatment with oral antibiotics. A score of 2 means we should consider a short inpatient stay for these patients. And then a score of 3 indicates that this is a high severity pneumonia and that we should seek senior review. And then a score of 4 or 5 means that we should be considering escalating the patient to the high dependency or intensive care unit if that is clinically appropriate. Next, we must consider the differential diagnosis for a community-acquired pneumonia. The first thing to consider is a pulmonary embolism. A PE can present with an area of consolidation on a chest x-ray due to infarction of lung tissue, so we should always have this diagnosis in the back of our mind, especially if the patient is not responding to antibiotics. We should also consider lung cancer as a potential cause of consolidation on a chest x-ray. When consolidation is seen, we normally order a repeat chest x-ray in 4 to 6 weeks to ensure the consolidation has resolved post-treatment with antibiotics. If it is not resolved, we then consider cross-sectional imaging of the chest to ensure the consolidation is not due to an underlying mass. And there are other differentials such as congestive cardiac failure and COPD and asthma exacerbations to consider.
Now let's look at the management. We would give antibiotics based on local microbiology guidelines. In Salisbury, this is IV Coamox or IV amoxicillin in older patients due to the risk of C. diff. We would also consider giving clarithromycin if it is a high severity cap to cover for any atypical organisms. We would also consider supportive oxygen, IVIs, chest physiotherapy, nutrition, and consider HDU or ITU if clinically indicated.
Some additional important key learning points is that statins interact with macrolide antibiotics such as clarithromycin, so you need to remember to stop the statin if you are starting the patient on a macrolide antibiotic. As we mentioned earlier, you should also get a repeat chest x-ray in 4 to 6 weeks to rule out underlying lung cancer as the cause of consolidation.
Thank you for watching today. You can find the rest of our videos on our YouTube channel or Blackboard for the local medical students.